Hello and very good evening to our dear students. I'm Dr. Ruchi Raj, your original guru for Prosthodontics. And if the screen is clearly visible, am I audible to you? All of this is fine. Please give me a thumbs up on the Telegram group. I see that today has been a day of slight delay in the session, so I don't want to waste any of your time. And just give me a quick thumbs up and so that I can confirm that you are able to see me, you are able to hear me clearly. Then we can begin with our session. Hi students, hi everyone. Just give me a quick thumbs up so that I know that you all are there joined in the session and you can see the screen clearly. You can hear me properly. We can begin ahead with the session. Fine. So I think the screen is visible well to you and we'll begin with the INI-CET Power Grant Test 4 cross to discussion. Right. Thank you for the confirmation, Sachin. And we come with the first question. Prosthesis that is shown in the image below. It will restrict the deviation of mandible. The key word over here is deviation. It will restrict deviation of the mandible during function. It functions against this clasp assembly of the opposing obturator prosthesis, thereby splinting the maxillary teeth against the lateral forces of it. What is the name of this metallic prosthesis that you can see in the picture? Is it a palatal lift prosthesis? Is it a conventional cast partial denture? Is it a simple centric stabilizing splint or is it a mandibular guide flange prosthesis? Now, the correct answer here is option number D, mandibular guide flange prosthesis. Were you able to attempt this, students, in the exam? Mandibular guide flange prosthesis? Students, were you able to attempt this? Now, I'll quickly first come how to deduce this answer. They are already saying that there is an obturator prosthesis with the patient. So option number A cannot be correct because we know palatal lift prosthesis is the prosthesis of maxilla. Centric stabilizing splint does not look anything like this because it will be covering the occlusal surfaces of the teeth. The confusion will always arise between option number B and D. Now, from the description of it, you can very well try and maybe figure out with little understanding that this is a prosthesis that is trying to guide the mandible and prevent deviation. That is how actually you can even deduce the answer to guide flange prosthesis. But let me explain the theory behind it. Now, in a mandibulectomy patient, in any patients with mandibulectomies, which means supposedly this is a complete maxilla and this is half of your mandible that is there. Whenever the normal side will come into occlusion, because the teeth will come into contact, it will create a point of fulcrum and it will create a rotational movement in the mandible. So the mandible will rotate like this, right? So there is rotation of it also and there is deviation towards resected side. Now, this is something that I need to tell you, and you must remember in any mandibulectomy patient, deviation will be towards the resected side always. Remember that. Deviation is always towards the resected side. Now, to prevent this deviation, because when the deviation happens, as soon as the point of contact is happening on the normal side, supposedly, it will shift the mandible and rotate it. So, teeth are not coming in proper occlusion. And to prevent this running away of mandible or deviation, what we do is on the opposing side will give something like this, which is called as a guide flange prosthesis. What it will do is it will try to splint against the opposing maxillary teeth over here. In this particular image, you can see there is a flange like this over here that is trying to hold against the opposing teeth. So it will prevent that lateral shifting of your mandible. So the correct answer here is a guide flange prosthesis. Mandibular guide flange prosthesis have different appearances. The design that we used to make, and see, this is something that I must tell you. Every article will also give you different appearances. So what you need to look out here is there should be a vertical flange that is trying to prevent the deviation of the mandible, and something pertaining to deviation will be mentioned in the question. That is how the design would be. There is no standard design or just universal one design of a guide flange. There are various designs according to the case. At AIMS, we used to make it out of ortho wire plus acrylic. So I may even give you or show you an image how we used to prepare. Maybe probably that can be used as an image if it comes in the exam, right? So that is how guide flange prostheses are. So the key point that you need to remember is it prevents deviation or running away of mandible. Deviation is usually towards resected site, and it is given in your mandibulectomy patients, right? All other prosthesis, palatal lift prosthesis, where is it used? Can anyone tell me where is palatal lift prosthesis used? Quickly, quickly, students, can you tell me? Palatal lift prosthesis, option number A. Where will it be used? Sudhashri, Sachin, Rani, all of our students that are commonly there, routinely present in all our sessions. Can you tell me? Palatal lift, yes. In cases of insufficiency, you will use bulb prosthesis. In cases of incompetence of vilopharyngeal region, you will use a palatal lift prosthesis. So excellent, Sachin. Very nice, actually, that you remember it from the previous class. Coming to second question, phenomenon where porcelain appears different under varying light. Can you tell me the answer to it, students? Question number two. Phenomenon where porcelain appears different under varying light conditions. What is it? Is it metamerism? Is it translucency, transmittance, or opacification? What would it be? Metamerism? Yes. So the phenomenon where your porcelain will appear different under different lights when view it under different lighting conditions, that phenomenon basically affects what? It affects the shade selection, right? Shade selection of porcelain or FPD is affected, and metamerism is the phenomenon, right? So, coming to question number three. Now, this is a good question. And firstly, I let you answer it. So, a maxillary prosthesis shown in the image below. Patient has undergone partial maxillectomy. Identify the prosthesis. Is it A, definitive obturator, B, RPD, C, complete denture, D, interim obturator? Students, tell me what could be the answer here? What could be the answer here? So, you're absolutely right. Option number D, interim obturator. Sometimes now I feel maybe we don't need these discussions because all of you are very well trained for your upcoming exam. So option number D, interim obturator is the answer. Now for those who could not figure out or who probably got this question wrong, I'll explain. Obturator is what? Something that is used to obturate the maxillary defect, and mainly there are four kinds of it. One is called as a surgical obturator. Second is called as a delayed surgical obturator. Third is called as your interim obturators. And fourth are your definitive obturators. Now, excellent. So, what is your surgical obturator? A patient is planned for surgery, comes to you before the surgery, and then when you make an impression of that particular maxilla and you outline the surgical defect that is going to be. The surgeon gives you the outline of the defect, you outline it, do the mock-up surgery on the cast, prepare a plate beforehand for your patient, and then immediately after the surgery, if you're going to insert it, that is a surgical obturator. Say for whatever reasons, patient did not come to you before surgery, or the plan of surgery changed during the OT, and then after your surgical obturator does not get fit properly into the maxillectomy defect. Almost 7 days after your surgery, what you do is you make another impression and you try and fabricate a plate for your patient, which is an obturator plate that is called as a delayed surgical obturator. Now, after a few weeks, when the initial healing of the wound has occurred, it is roughly called from 2 weeks to 2 months or even more than that, is the phase of your interim obturator. This is usually the phase that patient is going under radiotherapy and the wound is reorganizing and even shrinking. So during this phase we give, which is called as an interim obturator. Now the difference between interim and surgical obturator is that interim obturator will need a lot of adjustments because the wound is continuously reorganizing. Secondly, just for aesthetic purposes, we can give only anterior teeth on it. So if I had an obturator image with just anterior teeth over it and posteriors were not given despite being missing, that is even an interim obturator. Reason is that whenever tissue is in the phase of healing, you do not want to give occlusal forces and trauma over it. So anteriors will not generate occlusal force, so you can give anteriors for aesthetic reasons and posteriors are avoided. Now, after the wound is sufficiently reorganized and has healed completely, how do you come to know? Patient does not complain of repeated ulcers, and you can see a naturally good pink mucosa and sufficient duration from the point of surgery, which is roughly at 6 months. We start with the normal process of obturator fabrication. That would usually be your definitive obturator. It will have the same process as a cast partial denture fabrication, except that it will also have a bulb of the obturator that you adjust into the defect site. Otherwise, it will have your teeth and every other process that your normal CPD will have. So these are your four kinds of obturator. What you see in the image over here is an interim obturator. Now, you may ask or you may feel, why is it not a surgical obturator? And if surgical obturator was in the options, how would I figure out? First and foremost, no examiner would actually make on purpose such controversial questions where there will be surgical and interim obturator which look the same and still be in the options. But if someone actually wants to trouble you, then I'll suggest you, how do you see? You may have a patient with a NG tube, nasogastric tube. If the complete image of the patient is there, then that would be a surgical obturator or a delayed surgical obturator. Reason being that patient is still being tried to feed with the NG tube and patient is nearly close to the time of surgery. That is why the NG may be there. So you may be able to, if the complete face of a patient or something is shown to you, right? Second, the defect site, if you can see over here, it looks fairly pink, which is what good healing has occurred. But if you can see scab tissue formation, or you can see a generally reddish mucosa, and it has been mentioned in the question that patient is say within 1 week of surgery or something, then it is a surgical or a delayed surgical obturator, right? But generally such controversies may not be created. Also, if they are created, students nowadays do challenge them also. So you may get your full points for it. But just remember, we must always prepare for the worst situation. So that is why just that extra bit of information. So is it good to go, students? Should I go to the next question? Right? Should we proceed to the next question, which is from implants to avoid thermal bone injury? What is the critical temperature in degrees Celsius one has to maintain during the drilling phase while placing the implant? So what it is saying is during the osteotomy, what temperature one should maintain during the drilling phase while placing dental implants. And I must tell you, this is something that I was discussing with a fellow clinician just 2 hours back, where I was shared one X-ray of a posterior mandibular implant, and the implant had radiolucency around it roughly at 2 weeks. And what we were suspecting was either the torque was too high or there might be a thermal injury. So the correct answer to this question is 40 degrees. To avoid thermal bone injury, the critical temperature that one has to maintain, which means you do not go above 40 degrees. If you go above 40 degrees, then you will have thermal injury. And thermal injury will be what? It will be bone necrosis. Right, you will see radiolucency roughly at the intervals of, initially patient will come with the complaint of pain in the first week, and at the 2 to 4 weeks interval, you will see radiolucency in the x-ray, right? So that is thermal injury. Usually we see it in posterior mandible the most. Why? Because posterior mandible has B1 quality of bone, that is a very dense bone. So drilling in it, somebody may use force to drill in it, and that is how it could be. Now there is an additional piece of information. The temperature, how much above 40 degree can cause damage? As little as 3 degrees above 40 can also cause thermal injury. So that means instead of 40, if you even go to 43, you will have thermal injury, right? So just even 3 degrees above what is 40 degrees, which is normal, that can also lead to your thermal injury. Is this clear to all of you? The particular question pertaining to dental implants and what is the correct temperature? Is this fine? So Sudhashri, Sachin, then what else? Who are the students? I actually don't know your username, so I'm not able to. Okay, fine. I think it's fine for you. So we would go to the next component now. Fairly easy question if you have gone through all classes of RPD. Component indicated here shows what? Now, can you tell me what is the component over here with the label? Does it provide support, rigidity, reciprocation, or indirect retention? What does it provide? What is the answer to it? Yes, excellent. So this is a reciprocal arm and it provides you, which is what is called as reciprocation. Now always remember one point over here. Supposedly this image did not did have retention as your other option. What you need to look for? A retentive arm, or how do you want to differentiate between retentive and reciprocal arm? Will taper. So from the point of origin, it will to the point of terminus, it will taper. Whereas a reciprocal arm never does not have any taper. It will be from the point of origin to the point where the terminus is, the thickness will be the same. So if it is a retentive arm, it will taper like this, right? And a reciprocal arm will stay of the same dimensions like this, right? So supposedly, if this particular four options had retention in it, then you have to look into the image very closely and see which arm it is and identify by this concept of taper. So I hope that point is clear for all of you, students. Okay. Now, coming to question number 6, the component that serves as a definite junction between acrylic resin and metal is indicated by what? Is it a survey line, a finishing line, tripoding, or a proximal plate? The correct answer to this question is, can anyone please tell what is the correct answer? Is it survey line, finish line, tripoding, or proximal plate? Excellent. So the correct answer is option number B, finishing lines. Now, just some theory around finish lines. What exactly are they? When two different materials, such as your acrylic and metal, are going to come to a junction together, you cannot just have a tapered junction for it. You need the acrylic to end in a bulk so that it retains over the metal. So, we want to create a locking mechanism or an undercut that is created by your finish lines by creating an undercut of less than 90 degrees over there. So they are on the external as well as the internal surfaces, and they are planned junctions of your metal and acrylic. So the correct answer here is finish lines. Now, a patient with high caries index, short clinical crowns. Now, each point is important over here. High caries index, short clinical crowns, minimal horizontal overlap, requires a restoration of a broken down maxillary central incisor. Tooth is already broken down. Restoration of choice is what? Is it pin ledge crowns? Is it metal ceramic? Is it partial veneer crown or a porcelain jacket crown? Now, correct answer over here is a metal ceramic crown. You have very specific indications of metal ceramic crown in your textbook. What are the indications? Indications are what? That you have high caries index, you have short clinical crowns where aesthetics is important, where a large destruction of tooth is there. Specifically in your Rosenstiel only, that has been mentioned, that extensive tooth destruction is there. You have need for retention of the restoration. All of these are indications of metal ceramic crown. So option number B, these are actually proper lines only that have been picked from your textbooks. High caries index, short clinical crowns, minimal horizontal overlap, all have been mentioned in the indications of a metal ceramic crown, which is why the correct answer here is option number B. Where will you not use a metal ceramic crown? Where you find that there is a larger pulp chamber. So there is a possibility that you may actually encroach onto pulp, or you have a much more intact tooth structure, so you can use a partial coverage restoration over there. Or young patients, which in turn means that you have a large pulp chamber. All of these situations, you will not use a metal ceramic crown. Now, question 8. It is desirable to reduce the occlusal interference in the existing dentition of a patient before constructing a FPD. Why? Option A, to prevent trauma to the restoration itself, to reduce the amount of adjustment of the restoration after insertion, to maintain a more accurate anatomic occlusal surface of the restoration, or prevent duplicating the deflective occlusal contact in the restoration. Now, what they are trying to tell you is that already in the existing dentition, there is some occlusal interference or a prematurity or something that is wrongful occlusion is present in the patient. So, whenever, as a rule of thumb, remember, if you identify any occlusal prematurity before constructing any definitive prosthesis, you should always, either by selective grinding or whatever technique that is applicable over there, correct the occlusal prematurity, because when an occlusion is in itself wrong and in future can be traumatic to your patient, you do not want to restore in that occlusion. You first correct that occlusion of the patient, bring it to normalcy, and then give your new restorations in it. So the correct answer here is, you should always prevent duplicating the occlusal deflective contact in the restoration. So you should always correct it. Because if you don't do it, your restoration, new restoration that you created, that will also have a deflective occlusion in it, and that in turn will also require adjustment afterwards, which will be wrong. Right? We should always correct the existing occlusion of the patient if it has any problem. If you notice any wear, if you notice any wrong closing pattern, anything, whether it requires splint therapy, whether it requires additional crowns, whether it requires even extraction of teeth also, you need to correct the existing occlusion of the patient, then give any new restoration. Coming to question number 9. Incisal guidance, which is generally agreed to be the anterior path traveled by the mandible during functional movements, is a path that should never be altered during restorative procedures if a normal occlusion is to be maintained. Now, we know that incisal guidance is always altered, so option A is wrong. It is influenced by the contacting surfaces of mandibular and maxillary anterior teeth. Now, option number B sounds correct. Yes, option B is the correct answer. It is influenced by the contacting surface of maxillary and mandibular teeth. But let's look at option C and D. It cannot be influenced by anatomic relationship of the occluding surface of posterior teeth. No, that is wrong. It is definitely influenced by the posterior teeth also. And it cannot be changed by dentist. This is applicable to condylar guidance, not incisal guidance. So the correct answer here is option number B. It is very simple actually. If you try it out into your own mouth, and I'll ask all of you to do it simultaneously. Just open your mouth, bring your teeth edge to edge, then try to go into maximum intercussion. Just normally relax, open your mouth, bring your teeth edge to edge like this, and then just go into maximum intercussion. Now, when you are in that maximum intercussion, try to just open your mouth by 1 to 2 millimeters and protrude anteriorly. All of you just do that simultaneously, right? Question number 8. Okay, Sudhashri, I'll come to your doubt in question number 8. Let's just finish the discussion of question 9 here. So, what I was saying is just slightly open your mouth by 2 millimeters and protrude. When you protrude, you should feel that the labial surface of your mandibular anterior teeth, how the mandible is moving ahead, is governed by the angulation of your maxillary anterior teeth. So, if my maxillary anterior was straight like this, that is how it will govern the path of the mandible, because my mandible will move downwards and open faster. If my maxillary anterior was tilted like this, my mandible will move forward first rather than opening down much, right? So the angulation of maxillary anterior, mainly the palatal surface, is going to govern the entire movement also. So that is how the influence of these contacting surfaces is. Are you able to figure it out? Right now, this is something that when we do teeth arrangement in complete denture, you would have heard it a lot. It can be adjusted by dentists, it can be adjusted. How do you adjust it? I'll teach you how. When we do teeth arrangement of complete denture, I can put my maxillary anterior straight like this. I can give it this incline. I can give it this incline. I can even make it retroclined also. So that is up to me how I arrange my maxillary anteriors. Then it is up to me how much overbite I give to my patients in your complete denture. Whether I close it to this level, whether I keep an open bite like this, whether I keep it retroclined, all of this is going to influence your anterior guidance. If I had an articulator actually in hand, it would have been easier to explain. So that is how anterior guidance is adjusted for patients according to the overjet and overbite, and that is how it is influenced. So is this part clear for all of you? Then we'll move to question number 8. Just give me a confirmation. Is question 9 clear for all of you? What exactly is anterior guidance? Then we can move ahead to your question number 8. Students, okay. Now coming to Sudhashri, your doubt. You're saying that option B and D are more or less the same in question 8. No. Why is it not same? There is one thing, say for example, I construct a denture or I construct a prosthesis. My goal, ultimate goal, is to have as less adjustment in the final prosthesis as possible and make it the most accurate prosthesis. Option number B is what? When you don't know or rather you have not identified the occlusal interference in the prosthesis, and now you are trying to adjust it after making the restoration, which is technically wrong. The correct thing would have been to identify the occlusal interference beforehand, correct it into the patient's mouth, and then start the process of making a crown, so that you don't have to do the corrective procedure in the restoration. What option number B says over here is reduce the amount of adjustment of the restoration after insertion. So you are accepting that you are going to do adjustment in the restoration after insertion, and that is something that is technically not correct. Theoretically it is not correct. Practically a lot of people do this only. Theoretically it is not correct, right? So the better option is that you do not duplicate only the deflective occlusion into your restoration, or rather before forming the restoration you correct it and then you start the process of making a restoration, so you would get minimal to minimal adjustments, right? So B is a continuation of D, but D comes first before B. That is why D is the correct answer. I hope you are getting the gist of what I'm trying to explain you. B is a corrective thing that you have done after you could not identify the mistake. Right? So read the sentences. Try to see in an exam. Remember one thing: you have to be theoretically correct, not how a clinician would think. Which is why actually this is something that a lot of clinicians who take a drop 1 to 2 years after BDS and then come giving NEET, their judgments is sometimes blinded by their clinical exposures. Also, it's a good thing. It's a bad thing also. Bad thing is that they'll try to opt for such options which are clinically relevant, not theoretically relevant. Remember, especially in INICT, you have to be theoretically relevant, right? So the correct theory should be the answer. Now, prolonged sensitivity to heat, cold, and pressure after cementation of a crown or FPD is usually related to what? Now I'll tell you something. You open up your textbooks, you open up literature. The exact line as such is not available, but through years we have come to know that occlusion is the correct answer, which is followed, rather, which is something that has been taught to us also during PG. That if there is prolonged sensitivity to heat, cold, and pressure after the cementation of a crown, even say after a month or so, then definitely the problem is occlusion. The mechanism of it is what? Whenever you have a deflective occlusion, even when a crown is slightly high, it will lead to damage to the pulp of the tooth, and that is going to lead to sensitivity and pressure and pain, and that is the reason for it. But I have searched even textbooks and literature for it. I don't find the exact line that has been written in the question, but be assured this is the correct answer, because this is when the question had first come. Even a lot of rankers had attempted this particular answer for it. That is how even in my time we used to figure it out, when a lot of rankers attempted, right? So that is why we had come to the conclusion it is not a recent question, it is a PYQ, and that too a quite old PYQ. So the correct answer to is occlusion. The mechanism, what I understand out of it, is that when a tooth is slightly high, the first damage that happens because of occlusion is to the pulp of the tooth because of the high biting force. That will lead to internal sensitivity, that will lead to pain, and that will lead to sensation of pressure also, right? Specifically, if something pertaining to margin has been mentioned, then it will be open cemented, or that will be incorrect cementation, or right, rather an open cementum around the margin. So if something has been specifically mentioned that surrounding the margin of the crown patient has sensitivity, that is definitely exposed cementum of the patient's tooth, right? So correct answer is option number A. Now, again, a dental material question, just overlapping it in prostho. Which of the following dental cements, or rather a luting agent, is providing adhesion to calcified dental tissue? The correct answer is option number D, which is zinc polycarboxylate. It has specific chemical adhesion to tooth because they will form chelating bonds with calcium. So it can bond with enamel and dentine. Right? So correct answer is option number D. If you want to read about zinc polycarboxylate, please refer to your DM videos, because prostho videos won't have a descriptive explanation of it, right? Now, auricular implants. Auricular implants should be placed how many millimeters from external acoustic meatus? Last time what we had discussed is distance between two auricular implants, which was 15 millimeters. Now what we are discussing, how many millimeters it should be away from external acoustic meatus? Correct answer is 20 millimeters. Before your exam, actually, there are three things that I want to teach you about auricular implants. I'll even share the images of it in our group. One is the distance between two implants. Second is distance from external acoustic meatus. And third is the location of a right and left auricular implant. What clock position should it be placed? Somehow I have a hinge of it that this can be a question in future. So just remember these three values. I'll share it with you very soon. Right, so correct answer is option number B. Now, porcelain bonded to metal is strongest when, whether it is air fired, under compression, tempered after firing, or fired several times before completion. Remember, when you fire it several times, you often see something which is called as dark spots and even opaque appearance of the porcelain, right? So you would often see something like that. You may even see cracking of porcelain if you fire it several times. Why do I say? Because as students, we used to fire porcelain so many times. At the end of it, probably it might even crack also. So the correct answer here is always under compression. You all know porcelain is weakest under tension, strongest under compression. By or what do we mean under compression? When a certain thing is of this size in normal say situation, when you apply heat to it, it will expand, right? So the size of it increases. There is a veneering layer over it, supposedly that also expands, so right. So probably two things are like this, one on top of each other. Now when you apply heat to it, both of them expand, but the metal substructure that it is, that contracts more rather than the porcelain substructure. So what it will do, it will hold the porcelain under compression. This is a very laymanish way of explaining how compression works in metal ceramic bonding, but this is actually how it is. The coefficient of thermal expansions are like that, that when the contraction or coming back to normalcy happens, the metal will keep the porcelain under compression, so it will hold it like this, and that is how porcelain will stay stuck or bonded to your, what do you say, metal. So correct answer is under compression. So this would be the end of actually the last question. Now quickly going on to your telegram group, students, again, understanding mechanisms of crack propagation and everything, I'm sure Dr. Aishwarya would have taught it to you. And are you being taught what is headlighting in porcelain? Were you taught what is headlighting in porcelain? Because I framed recently only framed a question on headlighting. Do you know that particular terminology? What is called as headlighting in porcelain? Headlighting, like the headlights you have. Because I think in your NEET GT or something, I had made that question pertaining to headlighting. I'm just opening actually the question because it is relevant to this. So I thought I can just discuss it for you. Yes, headlighting in dental porcelain means what? Okay. So, yes, so I had actually framed that question for your NEET GT. And headlighting in dental porcelain is formation of uneven color and dark spots on the crown. Right? The reason for is that when you have uneven thickness of the original veneering material onto the crown, the thin spots will look darker, the thicker spots will become opaque, and you will have a dotted appearance on the crown, right? So the opaque porcelain is too thick, that leads to like a headlighting appearance on the crown. So uneven thickness and dark spots on the crown is called as headlighting in porcelain. I've been given the question in NEET GT. So you will find it over there in NEET GT paper. That time there I have included. Reason is that recently I saw this terminology being discussed. So I thought maybe you should all also be aware of it. Apart from that, I'll try to even post some numericals and questions for before your INICT, like how we recently did the topic of top five classifications from Prosto. These are bite-sized informations. Are these helpful to you, and should we continue doing videos like these for you? Because these are small bite-sized informations which I thought may be helpful to you. So we tried with the classification first. We can go further with numericals and other parts also. Just waiting for your telegram. I'm on the telegram group. Fine, sure. So I'll probably, if possible, I'm in process of making one pertaining to implants, five values pertaining to implants. Next, I was thinking to make something regarding auricular implants so that you have three, four numerical values pertaining to it. So we'll keep these videos churning so that you can just save them, quickly revise them before the exam. And I thought that could be useful. Now again, this completes your session for your power plan. I think all four tests are done now. This is the last test. Any queries or anything that you wish me to cover or ask, do put a message in Telegram or whichever group that you are on with me, and I'll be happy to solve them. Now, I wouldn't waste much time. I'll stop the streaming of this session here. Again, if anything was remaining or you could not understand, just drop a message. So I'll turn off the session here. Good luck and good evening, everyone. Bye bye.